Thank you for being part of this event, and we anticipate a productive and enlightening session ahead. Today, we are honored to have Dr. Patnaik, Mrinal Patnaik, as our esteemed guest speaker. Dr. Mrinal is a physician scientist within the Division of Hematology and professor in the Department of Medicine at Mayo Clinic. His primary focus lies in studying the disruption of epigenetics in age-related clonal hematopoiesis and myeloid neoplasms associated with aging. He holds the position of chair for the acute leukemia and chronic myeloid neoplasms disease-oriented group, and serves as the scientific director of the Center for Individualized Medicine Epigenomics program. Additionally, he co-directs the Mayo Clinic Comprehensive Cancer Center Precision Genomics program. Turning to our attention to logistical matters, I kindly request all participants to mute their microphones during our case discussion to minimize any background noise and potential disruption. Please feel free to share any questions or comments in the chat box, and we will address them at the conclusion of the presentation. Without further ado, let's extend a warm welcome to Dr. Patnaik as we begin our session. So first case is an 86-year-old male Asian patient back in March 2023, evaluated for thrombocytopenia and anemia with the hemoglobin of 9.5, with the WBC 9.5, with the platelet count of 55, with increased metamyelocytes and nucleated red blood cell peripheral smear. He did have an unremarkable SBEP, viral workup, and nutritional deficiencies for his bicytopenia. He proceeded with the bone marrow biopsy a month later, where bone marrow showed normal cellular bone marrow with multilineage dysplasia up to a 5 to 10%, with unremarkable flow for leukemia and lymphoma panel, with a deletion 20q per cytogenetics, but otherwise unremarkable MDS fish and NGS was not performed. The diagnosis of CCUS or MDS was made. So before he presented back in March 2023, he had a unremarkable blood work from April 2022 and decreased hemoglobin with the platelet count trending down back in August 2022. So the repeated bone marrow biopsy showed bicytopenia in a hypercellular bone marrow with multilineage dysplasia up to 10% nuclear budding and binucleation in erythroid precursors, 80% cellularity. Again, the cytogenetics showed deletion 20q, but otherwise unremarkable MDS fish. He did had the NGS panel where it showed BCOR mutation with VAF of 82% and U2AF1 mutation with the gain of function with a 40% VAF, and the RUNX1 mutation with the VAF of 38% and the PT-PRT copy number loss mutation. So flow cytometry, again, did not show anything abnormal and remarkable PNH, and the most recent blood work did not change, still persistent bicytopenia with unremarkable liver and spleen ultrasound. So I will leave up to Dr. Patnaik for discussion points.
Yeah, thank you, Dr. Taha, for inviting me. This is a very classical case that we encountered in hematological clinics. The difference between clonal cytopenias of undetermined significance and myelodysplastic syndrome can sometimes be very fine. It can come down to semantics. So for a diagnosis of MDS, as you pointed out, the World Health Organization and now the ICC, they both call for dysplasia in one or more lineage, that involves at least 10% or higher, of the observed cell population. And so sometimes you can see they use words such as atypia, or the dysplasia could be subtle, and it may not necessarily meet that 10% cutoff, in which case, the pathologist won't label this as MDS. And in the presence of a clonal abnormality, whether it is on NGS or, as in this case, a cytogenetic abnormality, they get left without a diagnosis, and clonal cytopenias of undetermined significance, unfortunately, does impact them because some of the treatment approaches that you would use for low risk MDS, it becomes hard to obtain them for CCUS just because it's not a recognized entity by the ICD-10 coding system. Insurance companies sometimes will not allow you to get certain medications. So I feel that there's a fine line. It's important to understand that while a pathologist can help you with morphology, cytogenetics, molecular genetics, all of them play a role, but clinical correlation and approaching the patient clinically is very important. And you will see with some of the slides that I have put together, some of these CCUS patients have a very similar morbidity, including transfusion-dependent profile as low-risk MDS. And so, I again urge everyone that, while this area is evolving, as a clinician at the end of the day, it's really important to approach this case by putting all this information together holistically so that you best help your patient with the right treatment approaches. The second question that you bring up is clonal hematopoiesis workup upfront for solid malignancy patients. So this is an area that is clearly evolving. Right now, we do this in a research setting. At Mayo Clinic, we established the CHIP clinic in 2017. And so we have a custom clonal hematopoiesis panel, which looks at about 220 genes, myeloid as well as lymphoid chip. And there are solid tumor patients that get referred, but there are two groups in particular that we pay special attention to. The first group are patients with ovarian cancer who are homologous repair deficient. So they either have germline, BRCA mutations or, mutations in that DNA damage repair and response pathway. And they have been exposed to platinum-based chemotherapy. So a lot of these patients get carboplatin with Taxol as a chemotherapeutic option. And now their physicians are considering PARP inhibition. So with the approval of PARP inhibitors in ovarian cancer, people have started seeing that there is a high risk of developing myelodysplastic syndrome and acute myeloid leukemia with short latent periods. And in many cases, we can detect pre-existing clonal hematopoiesis states. A lot of them involve genes such as PPM1D and P53. And if they are homologous repair deficient through germline mutations, have had exposure to mutagenic chemotherapies such as platinum agents, have a pre-existing CHIP state with PPM1D or P53, and now you put them on a PARP inhibitor, their risk of progression is quite high. And so these are patients that we are profiling so that, we understand their risk. The patients also understand fully, how this may impact their overall survival and outcomes. The other solid tumor that we are very interested in are neuroendocrine tumors. So as you're aware, these tumors involve, the gastrointestinal system, and there is a radioisotope that has been approved by the FDA called lutetium dotatate. And lutetium dotatate is a beta particle emitting agent, which has improved outcomes in patients with neuroendocrine tumors. But again, in this particular group, there is a higher incidence of MDS-AML. Reports have varied from 2.5% to 10% over the first few years of exposure. And this drug has now been approved for metastatic prostate cancer and is actually moving upfront with clinical trials being designed to treat patients earlier on in their course of disease. And we want to better understand, whether these therapy-related neoplasms that we are seeing can also be predicated by existing clonal hematopoiesis. So these are the two groups, that we in particular are interested in. It has a role also in adjuvant chemotherapy for younger women in particular with breast cancer, for example. If they're going to get dose-dense AC Taxol, Again, if they are homologous repair deficient with BRCA mutations in particular, or CHEK2, ATM, PALB2, if there is a benefit from adjuvant chemoradiation therapy, providing some information on their risk of therapy-related neoplasms, pre-existing clonal hematopoiesis states also help. So I think this area is evolving. I think right now, a lot of this should be done in the research space because there is no clinically orderable chip panel, for example. Reimbursement can be a big issue. We still don't know how to modulate outcomes. And so we strongly encourage such protocols come up so that we can study this and study the natural history. Your third question is, what is the approach to managing a patient with cytopenia and suspected CCUS MDS? So I think the approach is very similar to how we would manage lower risk MDS. Remember, at the end of the day, you're not treating the diagnosis, you're treating the patient. So if your patient comes to you and is, anemic, for example, and is now symptomatic or is going to need, blood transfusions, I approach it very similar to how I would with low risk MDS. If their endogenous erythropoietin level is still, less than 500, erythropoiesis stimulating agent therapy is, very reasonable as a first start. If they have ongoing neutropenia with infections, do they need to be on neutropenic prophylaxis for thrombocytopenia, or more generalized trilineage hyperplasia? Can drugs such as L-trombopag, if we can get insurance approval for DNA methyltransferase inhibitors, this would be, how we would look at that. But for CCUS, of course, there is a great need to do clinical trials because, we don't know the exact endpoints. We don't know a lot of data that you will see in CCUS with these agents is small case series, retrospective. So it's really important that, we do prospective studies, and we have done a few, and I'll show you one study in particular that we have just completed for CCUS. I think a big issue that we faced is response criteria. All the response criteria that we used were MDS response criteria, which may not be applicable to CCUS. So I think, the community needs to really get together and understand defining trial endpoints if trials are going to be successful. And your fourth question is, what is the rationale behind using a 2% variant allele fraction to define clonal hematopoiesis? So, this really has two parts to the answer. The first part is when CHIP was first defined, this is the Steensma paper in Blood in 2015, almost all the next generation sequencing panels, had a lower limit of detection of 2% variant allele fraction. Below that, you cannot really differentiate between amplification and sequencing artifacts versus true variants within the genome. And if you want to get below 2%, your assays have to have unique molecular identifiers, and it's a technique called error-corrected sequencing, which is not, widely available and can be quite expensive. So just by default, the first stab at this definition was to say, okay, as long as you are, 2% or higher, that may be a true variant, and we can call it. Anything below that, can be discarded. The second thing that supported that was in age-related clonal hematopoiesis. This is very important. So, my advice to everyone on the call is that it's important to distinguish age-related from context-related clonal hematopoiesis. So in age-related clonal hematopoiesis, when they use deeper sequencing techniques like error-corrected sequencing, they found that clones that were less than 2% variant allele fraction, often regressed or were clinically inconsequential. And so when they found biological basis along with a technical limitation of sequencing, they chose this cutoff, 2%. It is somewhat arbitrary because I said in context dependent, you may have a patient with multiple myeloma who has a P53 mutation with a VAF of 1%, who you're going to give melphalan to and an auto transplant. I would not ignore that, because in the next 3 weeks, when there is rapid marrow expansion of the hematopoietic precursors that you're giving after melphalan, that could expand and become much higher. Similarly, if you have a PPM1D chip with a VAF of 1% in a patient with ovarian cancer who's now going to get nelaparib or olaparib PARP inhibitor for 2 to 3 years, that clone cannot be ignored because it has a high likelihood of increasing. So anytime you approach clonal hematopoiesis, make sure that you distinguish age-related clonal hematopoiesis from context-relevant clonal hematopoiesis. And I just wrote an editorial 2 weeks ago in Leukemia Research. I can send you the link in the chat, where I go into much more detail on how this is important for the field. A lot of what you read in papers is age-related from the UK Biobank and from large exome sequencing studies, and that's very important, but that does not necessarily apply, en bloc to some of the cases that you may encounter in academic hospitals where you get referrals from, solid tumor patients, radiation patients. The field of radioisotope therapy is really going to expand. And I think as hematologists, we have to watch that space very closely, because there is going to be collateral exposure to hematopoietic cells. Your next question is, when do you become concerned about transformation from CCUS to MDS? I think, a lot of this depends on two things: your peripheral blood counts and your peripheral smear. So if your peripheral blood counts show a clear change in trajectory, so the hemoglobin has dropped to the point where they may be transfusion dependent, or very symptomatic, or their neutrophil counts have now dropped into the neutropenic range, they've become significantly thrombocytopenic, or if the blood smear shows circulating immature cells, whether they're blasts or other immature variants, I think that would be something that I use in my practice to decide when to repeat a bone marrow biopsy to see if it morphologically meets criteria for myelodysplastic syndrome. Now, CCUS is also evolving. There's clonal cytopenias with monocytosis. There's clonal monocytosis. So this is a broader term. You very commonly will encounter cases with cytopenias with monocytosis. And, if the monocyte count starts increasing above 500, definitely above 1,000, one of the tests that we do non-invasively is a monocyte repartitioning flow cytometry that looks at expression of CD14 and 16. And if the MO1 fraction, which is 14 positive, 16 negative, is greater than 94%, these patients may actually develop oligomonocytic CMML or CMML. And so you have to be aware that there are different trajectories that are shaped by the underlying somatic mutational landscape. Your next question is, what threshold of somatic mutation BAF prompts you to consider initiating a germline workup? I think this is a great question because, every time we do sequencing on the blood, for us, blood is almost always equivalent of the tumor, unlike solid tumor patients or other medical specialties where blood is considered their germline. So there are many mutations that we will see that, we will encounter, and it becomes critical to know that if your VAF is between 40 to 60%, or at least greater than 35%, I would stop and look and see whether this is one of the genes, especially if they have been implicated in germline predisposition. For example, RUNX1, ETV6, GATA2, DDX41. These are examples that you will encounter. GATA2 can be somatically mutated, it can be germline. RUNX1, same thing. DDX41, same thing. ETB6, same thing. So every time I see that 40 to 60% or at least more than 35%, I will make sure. At Mayo Clinic, we have developed a very interesting workflow where all our CHIP patients, we extract 20 hair follicles when we see them in the clinic. And if we see VAFs in this 40 range, we extract DNA from the hair follicle and validate whether these variants are germline before we provide results back to these patients. Your seventh question is, when do you decide to initiate treatment for CCUS? And my answer is, again, I would approach it very similar to low-risk MDS. So if this patient becomes symptomatic anemic, transfusion dependent, bleeding manifestations, needing platelet transfusions, symptomatic neutropenic, these are patients that you cannot just watch anymore. It would be ideal if we have a growing pool of CCUS clinical trials. That would be their first option, but understanding that we have a long way to go before trials can be widely available, largely because we need to understand what the trial endpoints will be. But trying to obtain standard of care approaches for low-risk MDS, whether it's erythropoiesis stimulating agents, TPO mimetics, even low-dose hypomethylating agent therapy, neutropenic prophylaxis, supportive care. That's how I approach this in my practice. And then your last question is, how do you perform risk stratification? This is an important question. And again, I would urge you to distinguish age-related from context-related. For age-related, earlier this year, Dr. Lachelle Weeks from Dana-Farber, as well as her team, they came up with a nice scoring system called the CHRS. And I have a slide on that where they have incorporated CBC data with sequencing data. So it has things such as DNMT3A mutation, other high-risk mutations, mean corpuscular volume, red cell distribution width, the extent of cytopenias, and they've come up with a nice risk stratification system that can predict evolution to myeloid neoplasms as well as impact survival. But in reality, when you see a lot of patients that you may encounter in your clinic are going to be context dependent, where, for example, in that paper that was published, because of a sequencing artifact that Illumina ran into with chromosome 21, they were not able to analyze the impact of U2AF1 mutation. So that model doesn't have U2AF1 in it. I can tell you that U2AF1 is one of the fastest growing somatic mosaic states that you will encounter in age-related CH. So you have to be well aware of reading all the nuances in these models. You have to understand that that model, predicted evolution at a particular time point, but it does not, and it cannot integrate clonal pressures that your patient will be exposed to. So you may have a P53 mutation, but if your patient now needs to undergo chemoradiation therapy and is going to be exposed for a few months to this, that is a very different context than somebody who you detect and is not going to be exposed to this and you're just going to follow. This is really the evolution. In 2015, this paper looked at patients with suspected MDS. So they had anemia, neutropenia, thrombocytopenia. They did a bone marrow with morphology and cytogenetics, and they found 3 groups. And this is what you're going to see in practice. One, where the pathologists are like, yes, this meets MDS criteria. There's no controversy. In 2, there's atypia. It doesn't meet the 10% cutoff. And in C, there's absolutely no atypia, dysplasia, blasts are less than 5%. So when they did sequencing, you can see that group A and B, 71% and 62%, had somatic mutations. So a lot of these CCUS patients without atypia or dysplasia meeting criteria for MDS, will have a very similar mutational landscape. So it's important to be aware, that these will behave. Now, the mutational composition can be slightly different. So if you look at the red bars, genes like SF3B1, RUNX1, EZH2, more common in MDS compared to the TET2, DNMT3A spectrum that we see, in CHIP-CCUS. So, these are the subtle distinctions. And, this is something that I use when I approach, CCUS, from a histopathological and morphological perspective. So, if they have cytopenias, at least for more than 4 months without alternative etiologies, and they don't meet the 10% dysplasia lineage specific cutoff, if their blasts are less than 5%, and they don't have an MDS defining cytogenetic abnormality in the presence of a somatic mutation, usually in CCUS, the VAFs are higher, 10%, sometimes even 20%. But it's, again, really dependent on the gene and the context. This is something that I use as a clinical approach, to how I call CCUS versus MDS. So I use the word CH more than CHIP because, clonal hematopoiesis really defines the presence of a somatic mosaic state in stem and progenitor cells. It's independent of the VAF. It can be seen with or without hematological neoplasms and can expand over time. So this is probably a more accurate reflection of what you are going to encounter in your day-to-day practice. Now, if you have somebody with a normal CBC without a hematological neoplasm, VAF greater than or equal to 2% in a leukemia driver gene, that fits the current criteria for CHIP. And then, of course, CCUS, we already discussed on the last slide. This, average of 4 months cytopenias is generally taken as a rule because, that's the time that a lot of reversible causes of cytopenias should, not persist beyond that. And so this gives you a time to eliminate, viral infections and other mimics of marrow failure that are acquired that may reverse without leading to a preneoplastic diagnosis, that CCUS becomes. So this is a paper that we wrote in Leukemia Research in 2021, which has a lot of definitions if you're interested. And, this is a summary of what the WHO over time has considered to be MDS defining. This is evolving. If you see in 2022, we had 2 slightly divergent classification schema with the WHO 2022 or the 5th edition and the ICC, where they still include monosomy 7, del7q, monosomy 5, del5q, and complex karyotype. But, there have been proposals, isochromosome 17q, 11q. What you can see on these slides is deletion 20q is not on it. So your patient that you presented had del20q, which is not specific to MDS. You can see it as a, clonal hematopoiesis abnormality in aging individuals. It can occur in the context of aplastic anemia, bone marrow failure syndromes. So other cytogenetic abnormality that you don't see on this list is trisomy 8. So you will encounter deletion 20q and trisomy 8 very frequently. Please do not label these as MDS defining. They are clonal abnormalities, but they're not MDS defining. In my approach, certain MDS defining, there's no question that deletion 5q with a associated cytogenetic abnormality, apart from monosomy 7, del7q, less than 5% blast is a well-defined entity. In 2022, SF3B1 mutations, now define MDS, with SF3B1, usually with ring sideroblasts, and the whole space of biallelic P53 is also evolving over time. And there's a whole group of AML defining translocations and mutations like NPM1, which even in less than 20% blasts, may now become more AML defining than MDS defining. So this space is evolving as we speak. But I thought I'll provide you with this list, which is quite useful. And this is a study that we published in 21 in Blood Advances, where we compared our Mayo Clinic cohort of CCUS with low risk MDS. So one of the questions, that you had put forward was, are we putting too much into this? I wanted to show you, if you compare it, the CCUS group had lower white counts, lower neutrophil counts, lower platelet counts. The MDS group were more transfusion dependent. Both had hypercellularity in their marrows. Of course, MDS had more ring sideroblasts because, that's the large part of low risk MDS is SF3B1 mutant MDS. And, both had some degree of progression. Of course, it was higher in MDS compared to CCUS. But I wanted to highlight that 22% of the CCUS cohort were receiving red blood cell transfusions regularly compared to 40%. So this is not, an indolent disease necessarily. What I will say is that the CCUS that we see in the hospital, there is a referral bias. These are patients who are obviously more sick and have more symptomatic disease. If you do a population prevalence, you may encounter a lot of clonal cytopenias that are asymptomatic and would never have come to light until they had an annual physical and somebody checked the CBC. So we still don't know the population demographics and outcomes of CCUS. All the papers that are published, have some bias because they are presenting to the healthcare, or they were detected because they regularly have physical exams and blood counts done. This is the risk score. I think this is a nice paper that Dr. Weeks, has published. What you can see over here is that DNMT3A is actually protective. If you have a single DNMT3A, your likelihood of progression is quite low compared to high-risk mutations such as, and you can see in the box below, Taha, if you can highlight that high-risk mutations with your cursor, there is no U2AF1, not because it wasn't high risk, but because they had a sequencing issue, and that it wasn't really, it's something that Illumina ran into with how they called the locus for U2AF1. And there are a lot of AML associated mutations like IDH1, IDH2, FLT3, RUNX1, JAK2, and P53. The VAF, the number of mutations, red cell distribution with MCV, things that you can get off the CBC, and age. You can see the panel C shows you that the high risk have a much higher cumulative incidence of myeloid neoplasms compared to the intermediate and low, which are quite close to each other. And that also impacts survival probability, which you can see in panel F. So, these are things that are being validated as we speak, but, an important tool that you can have in clinic when you work with that. Okay, next case. Good morning, Srinivasa. Thank you for inviting me.
Oh, thank you, Dr. Patnaik. That is very helpful so far. Excellent as usual. I'm going to read this second case. 82-year-old male, Caucasian history, initially presented to primary care with mild macrocytosis, MCV 103, monocytes with 14%, and platelet count 120 in 2012. And his hemoglobin and ANC were all unremarkable at that time. Over a period of time, I think his hemoglobin dropped to 11.8 in 2019 with MCV 118 and ANC also 1.9. And he had bone marrow biopsy in December 2020 that showed hypocellular marrow with lack of this erythropoiesis, and cytogenetics were normal. FISH panel is negative. However, NGS showed TET2, VAF 10%, and U2AF1 7% VAF. So he was diagnosed as CCUS at that point, and he was continued to be anemic with hemoglobin dropping to 10.6 and platelets also slightly decreased to 130. He did not require any transfusions, however, experiencing fatigue and low appetite, and ultrasound was unremarkable for any hepatomegaly or splenomegaly. He also had low haptoglobin, reticount was elevated to 7% with elevated LDH, but the other further hemolytic workup was negative. So he had again bone marrow biopsy, repeat bone marrow biopsy performed in June 20, 2023 that showed similar findings, unremarkable morphology and cytogenetics. However, he continued to have these two mutations in TET2 and U2AF1.
Excellent. Thanks, Dr. Srinivasa. So the questions are, what are the possible presentations of CCUS other than cytopenia? And this is really important because, as hematologists, we obviously worry about the cytopenias, but a lot of CCUS patients will present with inflammatory symptoms. You will be surprised at how many of them have spent months in rheumatological clinics being evaluated for polymyalgia rheumatica, giant cell arteritis, vasculitis. A lot of this is driven by the mutations that define CCUS. So, for example, we know that TET2 and DNMT3A, they're associated with activation of the inflammasome, overproducing cytokines like IL-1 beta, IL-6, IL-18. IDH mutations are also associated with systemic inflammatory autoimmune diseases. These are called as SIADs. And these entities, they mimic a lot of rheumatological conditions, but they don't meet the diagnostic criteria necessary. So a lot of our patients, and we see this a lot with CMML, also with MDS, they will come to you with temporal artery biopsies, which were negative, for example, for GCA, or they'll have leukocytoclastic vasculitis, and the P ANCA, C ANCA will be negative. So anytime you see that, and I think the best example of this is VEXAS syndrome, somatic mutations in UBA1, where while they have macrocytosis, cytopenia is a higher risk of MDS. They have the most severe inflammation that rheumatologists have seen, right from chondritis, auricular chondritis, costochondritis, vasculitis, arthritis. These patients, don't do well, high doses of steroids. The other thing that, you have to keep in mind is that as these TET, DNMT3A, JAK2 clones grow, they're associated with endothelial dysfunction. And so we do see a higher prevalence, of cardiovascular disease, a higher prevalence of cerebrovascular disease, again, driven by the underlying, genotype, that is causing CCUS. So between autoimmune inflammatory diseases, endothelial dysfunction related manifestations, there may be patients where the cytopenias are mild and don't even need management, and you have to focus a lot of your time on trying to control periodic fever syndromes, autoimmune. We had a patient that I saw in clinic yesterday with IDH2, ZRSR2, CCUS, who was hospitalized 6 times with fevers and ground glass opacities, that every time he came in, they would bronch him thinking he has some kind of infection, lung biopsy, when slowly over time his MCV increased and he developed monocytosis, cytopenias, exactly like your patient, and basically had a CCUS entity, which now we are treating with low dose hypomethylating agents. And after 2 cycles, a lot of his symptoms have already improved. So be vigilant for these non-hematological manifestations that you see with CCUS. The second question is, how frequently do we observe ineffective erythropoiesis? This really depends upon what is the driver for CCUS. So if your patient has SF3B1 or DNMT3A with another somatic mutation that can impact erythropoiesis in particular, you will start seeing a lot of these patients developing early onset anemia. The erythroid precursors will start showing atypia, nuclear budding. I will have to say this, and Dr. Chen, I think, will agree with me that dysplasia single lineage and erythroid series has to be interpreted with great caution. If you have some degree of hemolysis or any stress that is causing the erythroid lineage to go up, for example, in your patient, the retic count was, this patient looked like they were hemolyzing, but your hemolysis workup was negative, this could be because of ineffective intramedullary hematopoiesis involving the erythroid lineage, causing erythroid atypia just because of the regenerative stress on that lineage. So you have to be very careful when you see isolated dysplasia to the red cell lineage. But the presence of somatic mutations like SF3B1 would be very helpful, as you know, that causes development of ring sideroblasts where mitochondrial ferritin is trapped in erythroid precursors, leading to ineffective hematopoiesis. Question 3 is the likelihood of CCUS transforming to myeloproliferative neoplasm. Again, this is the driver that matters here. If your driver is JAK2, you saw, in the CHRS model, as well as what, I'll show you, this gene has a higher growth rate. And so, although it's acquired post-conceptually with a long latent period, once it starts evolving, and it usually occurs, in the second, third, fourth decade, progression to MPN, can occur over time. So I think you have to pay vigilance. Now, CALR and MIPL as CHIP mutations are very uncommon. There was a large Danish study that was published in Blood that showed that when they looked at 30,000 Danes, 3% of them had JAK2, whereas the CALR prevalence was, less than 1%. I think it was 0.5%. So those two drivers, fortunately, are not common. But JAK2 V617F, I would definitely watch carefully. Number 4 is, how do you manage symptomatic CCUS? I think we've already covered this in the prior slide. I would approach it similar to low-risk MDS. The only difference is, if they have SIAD or systemic autoimmune inflammatory disease, sometimes you may need to consider, and especially if cytokines, steroids, drugs like CellCept, etc., they become difficult to manage because CellCept can cause cytopenias. Azathioprine can be associated with progression, of neoplastic clones. So working closely with rheumatology just to make sure they don't make the cure of disease more grievous than the endurance of the same is important. Question 5 is various somatic mutations related to myeloid malignancies. I'll show you this in a slide that will come up, so I'll hold on this in the interest of time. And question 6 is, there is no NGS test, unfortunately, that is available for CHIP as of yet. I'm sure there may be something in the works, but commercially, different panels have largely been designed for heme malignancies and not so much for CHIP. They also don't focus on lymphoid CHIP, which has been detailed in the Nerula paper from Dana-Farber in Nature Medicine. At Mayo Clinic, we do have our own custom designed 220 gene panel CHIP, which goes down to a VAF of 1% using UMIs. We're hoping that we can move that into the clinical space. But as of now, I think everyone has to work, within the constraints of two things. One is lack of availability, and two is until organizations like NCCN or ASH or European organizations come up with recommendations on screening, which is evidence-based, insurance companies are going to give us a very hard time, in reimbursing sequencing panels that you would be doing. So I would urge you to keep that in mind, because many times that cost then goes to the patient and they, have to pay exorbitant amounts of money. Question 7 is any approved medications for CCUS? Unfortunately, no, nothing approved. We have clinical trials. The trial that we just completed, Dr. Shi, who is now at Moffitt, who was a fellow here, is writing that up as we speak. We wanted to treat TET2 mutant CCUS. That TET2 is a dioxygenase that converts 5-methylcytosine to hydroxymethylcytosine. There are 3 TET enzymes in the body: TET1, TET2, TET3. TET2 and to some extent TET3 are in the hematopoietic space. And we know that TET enzymes need iron and ascorbic acid or vitamin C as a cofactor, for them to function. And so we designed a trial where we wanted to give high dose IV ascorbic acid to patients with TET2 mutant CCUS. And, we have completed enrollment right now. And so we're in the process of analyzing data. And I can tell you one of the biggest challenges we had was, we had to use the 2018 IWG MDS endpoints, which really are not necessarily the best for CCUS. So I think there's a lot of work that we have to do. Dr. Borati at Ohio State has a canakinumab study, which is an IL-1 beta antibody, which has a long half-life that has shown retrospective efficacy in the CANTOS study that was done for cardiovascular disease. I know Novartis has a very exciting compound. It's an NLRP3 inhibitor, which is an inflammasome inhibitor. We have just opened the study for low-risk MDS and CMML, and the FDA wants safety data before that drug can move into the CCUS space. Dr. Kelly Bolton and Eitan Stein at WashU and MSK, they have an IDH1, IDH2 inhibitor CCUS chip study that they have accrued, and they're seeing good results with that. Data may be coming in the next ASH meeting. And there's an oral vitamin C study, there's a metformin study. So there are different clinical trials that are available, and we will have to wait and see how they perform. But I can tell you across the board, all of us, we've all greatly struggled in defining inclusion criteria, in defining what is success of these drugs. How do you measure non-hematopoietic results? Do variant allele fractions change in these patients? Are quality of life endpoints, worth including? So, another huge discussion. So really, this was one of the first papers that showed that, mutations matter in progression. So if you look at panel C and D, myeloid neoplasm-like mutations, which included genes like splicing factor P53, or multiple mutations, that's the red line showing, progression compared to just the CH-like mutations such as DNMT3A, or an isolated TET mutation in the elderly. So DNMT3 is very interesting. It is the most frequent CHIP mutation in general, but as you get older, because its growth rate and prevalence incidence starts dropping, TET2 actually becomes the most common mutation in octogenarians and nonagenarians. And in CCUS, TET2 is definitely the most common mutation, and DNMT3 is less common. And this, I'll really want you to focus on panel C. This is a very important slide. This tells you the growth rate. This was done by the Cambridge group, the Sanger Institute, where they did phylogenies and sequencing and then had a few prospective samples. You can see to the extreme left, the two slowest growing somatic mutations are DNMT3 and P53. In fact, if you look at the 0% bar, P53 copy number loss sometimes can shrink and disappear with time. It's counterintuitive. You may get a 17p deletion and you may say, oh boy, this is very bad, and that's how we are trained to think. But the R882, for example, is in the MTT domain of DNMT3A and is very prevalent in AML MDS. But look at it, its growth rate is much lower than even TET2 or Sybil. And if you go to the right of that panel, JAK2, PTPN11, SRSF2, and what do we have? The fastest growing mutation, apart from the P95 SRSF2 hotspot, is U2AF1. And guess what? In that CHRS model, they could not analyze the impact of U2AF1 on progression because of a sequencing issue. So Dr. Srinivasa, it's so important for us to read these papers properly so that if you don't read that paper, your impression will be that, oh, U2AF1 is not a high risk mutation, correct? So very, very important that we must focus. I encourage you and Dr. Bhatt and Dr. Osterk to maybe also introduce an element of journal club in some of these, or some hardcore evidence-based dissection of papers, so that all your listeners will know how to interpret it, to benefit patients. And this is the JAK2 story. This is a phenomenal paper from Jyoti Nangalia, again in the UK. It changed how we approach CHIP. We all thought that CHIP occurred, as you age, but if you look at the panel A on the left-hand side, it shows that JAK2 mutations actually are acquired in embryogenesis. So after gastrulation, during morulation and blastocyst formation, you can see the small red line, the JAK2, and then as they progress, they develop additional mutations, but most important, copy number alterations. So loss of heterozygosity of 9p24 where JAK2 sits, or duplication of 9p24. This leads to phenotypes such as polycythemia vera, essential thrombocythemia, or primary myelofibrosis. And this is what we published out of Mayo. This is again Dr. Shee's. It's a small retrospective series. It seems out of all the drugs that these CCUS patients got, there is activity with hypomethylating agents. They're off-label for CCUS in my practice. I use low-dose hypomethylating agents. So if I go with decitabine, I would do 20 milligram per meter square daily for 3 days. If I do AZA, I would do 50 milligram per meter square for 5 days. You don't want to give them as tremendously cytotoxic approaches, but you want to exploit their epigenetic activity so that they can restore hematopoiesis, by reprogramming the unaffected stem cell pool. And, these are the trials I already told you about: enasidenib, ivosidenib, ascorbic acid, canakinumab, NLRP3. The FDA just approved colchicine for cardiovascular patients who have a elevated high sensitive C-reactive protein. And there is data on colchicine modulating the inflammasome. So it's an interesting drug. They're so clever, these companies. They use 0.5 milligrams in the cardiovascular trial, when the colchicine that we use for gout pericarditis is 0.6. I bet you they will rebrand this as a very expensive medication with a different dose, like they did with sildenafil for pulmonary hypertension. So, and then MDS directed off-label ESA, HMA, eltrombopag, GCSF, drugs such as danazol. And this is the IV ascorbic acid trial that I was talking about. We're exploiting that red box there where vitamin C accelerates the unmutated TET2 allele as well as TET3, increasing expression, promoting the conversion of hydroxymethyl, to oxidative metabolites.